The shoulder joint, also known as the glenohumeral joint, is an articulation between the scapula and the humerus. It is a ball and socket type synovial joint, and it is one of the most mobile joints in the body. In this video, we shall look at the anatomy of the shoulder joint, its structure, blood supply, and some clinical implications associated with it. Let's start with the anatomical structures of this joint. The anatomical structures consist of the articular surfaces, ligaments, joint capsule, and bursae, which make up this joint. Talking about the articular surface, I would like us to know that this joint is formed by an articulation between the head of the humerus and the glenoid cavity of the scapula. This is the reason why this joint is also known as the glenohumeral joint. Like most synovial joints, the articulating surfaces are covered with hyaline cartilage. The head of the humerus is much larger than the glenoid fossa, giving the joint a wide range of movement. In order to make the head of the humerus fit into the small glenoid cavity of the scapula, the cavity is deepened by a fibrocartilage rim called the glenoid labrum. The joint capsule is a fibrous sheath that covers the structures of the joint. It extends from the anatomical neck of the humerus to the border of the glenoid fossa. The joint capsule is lax, making it possible for the joint to be more mobile, most especially abduction movement. A membrane called the synovial membrane covers the inner surface of the joint capsule and produces synovial fluid to reduce friction between the articular surfaces of the joint. Ligaments play an important role in stabilizing the shoulder joint, and they consist of the glenohumeral ligaments, coracohumeral ligament, transverse humeral ligament, and coracoacromial ligament. The glenohumeral ligaments comprise of superior, middle, and inferior ligaments that extend from the humerus to the glenoid fossa, reinforcing the joint capsule. They act to stabilize the anterior aspect of the joint. The coracohumeral ligament extends from the base of the coracoid process to the greater tubercle of the humerus. Its function is to support the superior part of the joint capsule. The transverse humeral ligament extends between the two tubercles of the humerus. It holds the tendon of the long head of the biceps in the intertubercular groove, while the coracoacromial ligament extends between the acromion and coracoid process of the scapula, forming an arch-like structure over the shoulder joint. This arch-like structure is called the coracoacromial arch. The work of this ligament is to resist superior displacement of the humeral head. There are two bursae present in the scapula, and there are subacromial and subscapular bursae. These bursae are sac-like structures containing a small amount of synovial fluid. The function of these bursae is to decrease friction between tendons, bones, and skin during movement. The subacromial bursa is located deep to the deltoid and acromion and superficial to the supraspinatus tendon and joint capsule. Its work is to reduce friction under the deltoid and promote free motion of the rotator cuff tendons. The subscapular bursa, on the other hand, is located between the subscapularis tendon and the scapula. It reduces friction on the tendon during movement at the shoulder joint. There are still other minor bursae present between the tendons of the muscles around the joint. Let's look at the movements seen in this joint. It is important we note that the shoulder joint is a very mobile joint, with a wide range of movement possible. The following movements are seen in the joint, namely extension. In extension, the upper limb is moved backwards in the sagittal plane. The muscles involved are the posterior deltoid, latissimus dorsi, and teres major. Another movement that happens in this joint is flexion. In flexion, the upper limb is moved forward in the sagittal plane. The muscles that perform these actions are pectoralis major, anterior deltoid, and coracobrachialis. Biceps brachii weakly assist in forward flexion too. Abduction too is part of the movement done by this joint, and in this movement the upper limb is moved away from midline in the coronal plane. It is carried out by the following. The first 0 to 15 degrees of abduction are produced by the supraspinatus. The middle fibers of the deltoid are responsible for the next 15 to 90 degrees, and past 90 degrees, the scapula needs to be rotated to achieve abduction, which is carried out by the trapezius and serratus anterior. Adduction is also carried out in this joint. In adduction, the upper limb is moved towards midline in the coronal plane, and the muscles involved are pectoralis major, latissimus dorsi, and teres major. Internal rotation is another movement done in this joint, and it is the rotation of the upper limb towards the midline so that the thumb is pointing medially. The muscles that perform this movement are subscapularis, pectoralis major, latissimus dorsi, teres major, and anterior deltoid. External rotation is also among the movements carried out in this joint, and it is just the rotation of the upper limb away from the midline so that the thumb is pointing laterally. The muscles involved are infraspinatus and teres minor. The last movement performed in this joint is circumduction. It is the movement of the upper limb in a circle, and it is produced by a combination of the movements we just described. Let's look at some of the things that make this joint mobile and also other things that make it stable too. Like we mentioned earlier, the shoulder joint is one of the most mobile in the body. This mobility is at the expense of the stability of the joint. The factors that bring about mobility of the joint include the following. The first one is the joint type, which we already know to be a ball and socket joint. Another factor is the bony surfaces, which are a shallow glenoid cavity and large humeral head. Also, the joint capsule brings about mobility to the joint. Then the factor that brings about stability to the joint are the rotator cuff muscles. These muscles surround the shoulder joint, attaching to the tuberosities of the humerus while also fusing with the joint capsule. The resting tone of these muscles acts to compress the humeral head into the glenoid cavity. Another factor that brings about stability to this joint is the glenoid labrum. It is a fibrocartilaginous ridge surrounding the glenoid cavity. It deepens the cavity and creates a seal with the head of the humerus, reducing the risk of dislocation. Ligaments, too, are another stabilizing factor of this joint. They act to reinforce the joint capsule and form the coracoacromial arch. The biceps tendon also brings about stability to the joint. It acts as a minor humeral head depressor, thereby contributing to stability. Let's briefly look at the blood supply to the joint. The shoulder joint is supplied by the anterior and posterior circumflex humeral arteries. These arteries are both branches of the axillary artery. There are also contributions from the suprascapular artery, which is a branch of the thyrocervical trunk. As for the nerve supply, the sensory innervation to the shoulder joint is from the axillary and suprascapular nerves. As we have been able to really understand the shoulder joint and what makes it to function properly, let's look at some of the things that can go wrong with the joint. One of those things that could go wrong with the shoulder joint is dislocation at the joint. Clinically, dislocations at the shoulder are described by where the humeral head lies in relation to the glenoid fossa. Anterior dislocations are the most common, that is about 95% of the time, although posterior, which is about 4% of the time, and inferior dislocation, which is 1% of the time, can happen too. Superior displacement of the humeral head is generally prevented by the coracoacromial arch. An anterior dislocation is usually caused by excessive extension and lateral rotation of the humerus. The humeral head is forced anteriorly and inferiorly into the weakest part of the joint capsule. Tearing of the joint capsule is associated with an increased risk of future dislocations. Hill-Sachs lesions, which are an impaction fracture of the posterolateral humeral head against the antero-inferior glenoid, and Bankart lesions, which are the detachment of the antero-inferior labrum with or without an avulsion fracture, can also occur following anterior dislocation. Indeed, so-called reverse Hill-Sachs lesions, that is the impaction fracture of the anteromedial humeral head, and reverse Bankart lesions, which are the detachment of postero-inferior labrum, can be seen in posterior dislocations. The axillary nerve runs in close proximity to the shoulder joint and around the surgical neck of the humerus, and so it can be damaged in the dislocation or with attempted reduction. Injury to the axillary nerve causes paralysis of the deltoid and loss of sensation over the regimental badge area. Another thing that could go wrong with the joint is rotator cuff tendinitis. Remember that the rotator cuff muscles have a very important role in stabilizing the glenohumeral joint. They are often under heavy strain, and therefore injuries to these muscles are relatively common. The spectrum of rotator cuff pathology comprises tendinitis, shoulder impingement, and subacromial bursitis. Tendinitis refers to inflammation of the muscle tendons, usually due to overuse. Over time, this causes degenerative changes in the subacromial bursa and the supraspinatus tendon, potentially causing bursitis and impingement. The characteristic sign of supraspinatus tendinitis is the painful arc. Painful arc is the pain in the middle of abduction between 60 and 120 degrees, where the affected area comes into contact with the acromion. This sign may also suggest a partial tear of supraspinatus muscle. Alright guys, that is on the anatomy of the shoulder joint. I hope this video was helpful enough. Support Joan Academy by subscribing to this page. Share also with your friends. See you next time. God bless you immensely.